Okay.
Hi.
Hi.
Thanks, Richard, for coming along to do this interview for the Nuclear Medicine, Molecular Medicine podcast. We're in Santiago at the 2016 Society of Nuclear Medicine meeting, and since we last met, a lot of things have happened.
Yes, that's true.
And I noticed that you published a paper recently on dealing with prostate cancer, which is one of the most common and most difficult to manage cancers that we have. If you could tell us a little bit about where you are and what you do, and tell us a little bit about the paper that you just published.
Okay, yeah, my name is Richard Baum. I'm the chairman of the Theranostics Center and the clinical director of the Department of Molecular Radiotherapy at Zentralklinik in Bad Berka in Germany. And we started actually working with radiolabeled peptides for diagnosis and treatment of neuroendocrine tumors long ago, 20 years ago in 1997.
Yes.
And we organized the first World Congress on Theranostics in 2011 in Bad Berka in my center with 400 participants from 56 countries, which at that time demonstrated for the first time, I think, the real interest in theranostics.
Yes.
So in using peptides, to predict if a therapy really can work in a patient.
Yes.
And in neuroendocrine tumors, there is meanwhile, as you know, this prospective clinical trial, the NETA-1 study finished, which has really proven that this concept of treating tumors with radiolabeled peptides is superior to conventional treatment.
Yes, yes.
So there is a longer progression-free survival, and there will be also, I'm sure, a better overall survival. So in 2013, actually, we took this experience from neuroendocrine tumors to prostate cancer. And that was possible because of a collaboration between our center and the Technical University of Munich with Professor Wester's group, who produced PSMA, prostate-specific membrane antigen, which is actually an enzyme which is present in prostate cancer cells. It's a transmembrane enzyme which can be targeted by certain ligands, and we can label these ligands with gallium-68 for diagnosis. And we started with that already in 2012. And it was really amazing because PSMA is highly expressed in this prostate cancer. And it allows to detect very small metastases down to a size of 2-3 millimeters, something we were dreaming about 10 years ago. And
very hard to pick up prostate cancer because it's so slow growing that FDG and other imaging methods like MRI just don't pick it up at all, or hardly ever pick it up at all until the prostate's well spread.
Yeah, and the role is not so much in the primary diagnosis, where MRI, still is a imaging modality of choice, maybe in combination also with PSMA, so one can do PET MRI using gallium-68. PSMA, like the group again in Munich has shown and published. But what is more important is the recurrent tumor. And these tumors are usually treated by hormones.
Yes.
So ADT or androgen deprivative therapy.
Right.
Okay. And that leads in nearly all the cases to a response to the treatment, but only for some time.
Right.
So after 2, 3, 4 years, these metastases, these tumors recur and start to grow again. And that's where we come in, because PSMA is mostly expressed in far advanced and undifferentiated tumors. And it allows, as I said, to image these metastases in lymph nodes, but also in lung, in liver, and in bones,
Right.
where they are most frequent. And then we can take the same small ligand and label it with lutetium-177,
Right.
which is a beta emitter.
Right, and it's also, you've used it previously in other therapies.
Yes, and we have performed approximately 5,000 peptide therapies in neuroendocrine tumors with lutetium more than 3,600. And so we could use our experience from the past, and we started in 2013 to treat prostate cancer. And meanwhile, we have done approximately 150 patients. I think it's the largest series in the world, with very advanced disease. This is not only what we call castrate or castration-resistant prostate cancer, but these cancers are also resistant to chemotherapy. The patient had received operation, hormone therapy, chemotherapy, and also what we call the new drugs, like abiraterone and enzalutamide, which are more effective hormone blockers.
Yes.
But still, the disease is then progressing.
Right.
So we were really last line. And you asked for the paper. So the paper we have published in the Journal of Nuclear Medicine, which is online since January this year, was a group of patients with far advanced disease. So treatment last line after all the therapies I just mentioned.
Well, prostate cancer in numbers is one of the biggest killers of all cancers.
Absolutely, yeah. It is one of the most frequent cancers around the world. So there are differences actually in the southern and northern hemisphere. There are difference in incidences, but in men it's definitely one of the greatest killer. And if there is no treatment after chemotherapy and the new drugs. Okay?
Right.
So this is a new opportunity, and despite this last line therapy, we were very successful.
How successful were you?
Actually, we saw a response in more than 80% of the patients.
And these are people that had failed everything else.
They have failed everything else, and we had a progression-free survival, which is really amazing, of around 13.7 months. Okay.
Right.
So, and the overall survival was not reached after this observation period. So this is, something where chemotherapy offers a survival benefit of just 2 or 3 months.
Right.
We had a progression-free survival of about 1 year or longer.
Wow, that's a bit dramatic. In the worst possible situation.
In the worst possible situation. And it's not only prolonging life. I mean, what is for me, I'm still, working a lot with patients in the hospital. I'm a real clinician, not only doing research. And seeing these people, people coming in a wheelchair because they had so extensive bone metastases and pain.
Yes.
And then after one single course of treatment, they came with their own car and walking.
Wow.
And the pain reduced
quality of life. Yes.
The quality of life improved dramatically. So I think this is one of the biggest chances actually nuclear medicine has for the coming 10 years.
Right.
Because in my feeling, it will be probably the most important therapy for nuclear medicine after radioiodine therapy,
Yes.
which by this way this year has a 75th anniversary
Yes.
of starting radioiodine therapy in patients.
Right. So you found with the other Theranostics that they worked very well in very difficult to treat cases, but then gradually you started to use it earlier and earlier in the process and you got even better results. Do you think the same thing might happen with prostate cancer?
I'm absolutely sure. We have meanwhile treated also patients not in last line, so after failing all therapy, but also in an earlier situation. These were interestingly all medical doctors who refused chemotherapy. Medical doctors with prostate cancer. colleagues. So they said, no, I do not want chemotherapy because, you know, an advantage of 2 or 3 months.
It's not worth it.
It's not worth it. Yeah,
Yes.
if you look at the possible adverse effects and so on, so they said, no, I do not want chemotherapy. Or there were some patients who could not tolerate chemotherapy
Right.
due to other conditions. And the response is even better in this earlier patient group. Okay?
Right.
So for the future, one have to think how to put this therapy in which order, and I'm sure it will come from last line, maybe not first line, because hormonal therapy is still very effective and has not so huge side effects.
Right, and there is a group of prostate cancers that are so slow growing that that it's not treatment with other than hormone therapy is probably not indicated.
You are completely right. I mean, prostate cancer is not a single cancer type.
Right.
It's a very heterogeneous disease where we have very aggressive tumors,
Yes.
okay, which kill patients actually within a month. You know, I call them the Zappa cancer. You know, Frank Zappa,
Yeah.
the famous
Yes.
rock musician,
Yes, yes.
who died also of prostate cancer in a young age.
Right.
So these are young-aged patients, you know, with very aggressive tumors, and there is this more slowly growing, very benign behavior in old patients. You know, and I think one really have to differentiate and find in future, you know, more indicators which is a more aggressive form of disease and which is a more benign behavior. And PSMA is expressed mainly in these very aggressive tumor types.
I mean, one of the issues, though, I mean, you've had very successful therapy with the other Theranostics, but you've had difficulty getting it into the US, for example. I mean, if you like, the Steve Jobs cancers, if you like, you had the... I mean, people really would have benefited from that. Let's hope we don't have the same long span in getting things into the US like we've had
I'm
before.
absolutely sure that in prostate cancer it will be much faster.
Right.
You know, I had a lot of contacts to industry here at the Congress in San Diego, and there are many companies really interested in planning already now clinical trials in prostate cancer with lutetium PSMA.
Right.
So it took us actually more than 20 years from the first therapy, which was performed in Basel in '96 with yttrium-90 DOTA-TOC, and later on in Rotterdam with lutetium DOTA-TATE to the NETA-1 trial.
Yes,
it took
yes,
about
yes.
20 years.
Do it quicker than yes.
Yeah, and I'm absolutely sure with PSMA, because it's of course also a very attractive market for industry.
Yes.
It will, start maybe end of the year or beginning of next year. I know of plans starting a, prospective trial in Germany, especially, but there are also a lot of companies, thinking about using it at the last line, but probably also at a previous time point, to treat metastatic prostate cancer.
You're changing the world.
Oh, I hope so very much, yeah.
Right, no,
And,
you are. I mean, we're dealing
yeah.
with, almost the most common cancer, probably breast cancer is still more common, but certainly the most difficult to treat cancer in terms of common cancers. And this will change the world. I mean, it'll make the world a better place for most families.
I think what is really most important is that it will change the life of many patients,
Yes.
to the better.
Yes.
And as I mentioned, reduce pain,
Yes.
reduce symptoms in advanced diseases. And that's very satisfying to see that you can offer a new kind of therapy. And Theranostics is so fascinating because you can immediately show to the patient and to your colleagues, that the therapy will work.
Yes.
We see what we treat.
Yes.
And that's, I think, a big difference to chemotherapy,
Yes.
where you throw something in a black tunnel.
And you might get a blood test or something, but you can't really see where it is and how it's working.
And of course it works in many patients, but it also fails in many patients.
Yes.
And for the individual patient, You never know, is this a patient who will respond very good to chemotherapy, or is this a patient who will not respond to chemotherapy? And that is, I think, the advantage of Theranostics, that we can in some way predict, that therapy will work and that there will be a response.
Right. Now, there's another meeting coming up in the Theranostics meeting.
Yes. Actually in your home country,
yes,
and in your home city, in
yes,
Melbourne.
Yes, that's right.
In November we will have the 4th Theranostics World Congress. So as I mentioned, the first took place in our center in Germany, in Bad Berka. The second one was in India, the third one in the United States in collaboration with Johns Hopkins University, and this is now the 4th one.
And there's new cancers being looked at this meeting, isn't there?
Yes, definitely. Rod Hicks will be the president,
right,
the Congress president, and Michael Hoffman, scientific secretary, together with me. And it will be, I'm sure, a fascinating Congress. We have very good speakers, very renowned speakers, and a lot of new topics. Not only gallium-68, but probably
copper,
also other labels, copper-64, F18 for labeling of peptides. So it's a completely new world opening.
Excellent. Well, I'll see you there. Thank you very much for helping us out.
Okay, see you.
Yes.
Good.